Welcome back, everyone, to today's Explainer. Look, if you want to completely master the clinical nuances of adult ventriculomegaly and LOVE without missing a single detail, so you don't actually have to go back and read the entire book, you are in the absolute right place. We're going to meticulously break this down point by point so every single concept locks right into your brain. Let's dive in. Here's our quick roadmap. First, defining ventriculomegaly. 2, the core criteria of LABA. Then we'll break down the specific clinical clusters, clusters 1 and 2, then 3 and 4, and finally, cluster 5, pan-ventriculomegaly. All right, section 1, defining ventriculomegaly. So the dual nature of ventriculomegaly, or VM, is actually pretty fascinating. Technically, it just means ventricular enlargement, but clinically, it happens for 2 entirely different reasons. First, you've got an actual increase in cerebrospinal fluid pressure, that's hydrocephalus. But the second reason is totally different. It's due to the loss of brain tissue, or parenchyma. You might hear this called ex vacuo. It's basically the ventricles expanding just to fill the empty space left behind. Another huge takeaway from the source text is that while ventricular size naturally increases as we age, that rate of increase goes up significantly in patients with Alzheimer's disease compared to healthy folks.
Moving on to section 2, the core criteria of LOVA.
Okay, so LOVA. It stands for long-standing overt ventriculomegaly in an adult. The most important thing to grasp here is that LOVA isn't just one single disease. It's a really heterogeneous group of conditions. So when we use terms like arrested hydrocephalus, compensated hydrocephalus, or aqueductal stenosis in adults, we're usually talking about LOVA. Now, clinically, when a patient fits this profile, it usually points to a really interesting origin story. Congenital hydrocephalus that somehow just went completely undetected or untreated during childhood and is only now showing up in adulthood.
And one of the absolute biggest clinical clues we have, head circumference. An adult head circumference greater than 59 centimeters in males or greater than 57.5 centimeters in females is a massive red flag. When you see those numbers, it strongly suggests that congenital hydrocephalus was likely there all along. The skull literally expanded during early development to accommodate all that pressure, and the patient just carried it right into adulthood.
No, to officially diagnose LOVA, we have to stick to a very strict 3-part definition. First up, imaging has to show ventriculomegaly involving the lateral and third ventricles, specifically excluding the fourth, along with obliterated sulci. Second, you need clinical findings. This can range from macrocephaly, like we just talked about, to headaches, cognitive decline, or even gait and urinary issues. Sometimes it's as severe as akinetic mutism or Parkinsonism. And finally, number 3, you need evidence of long-standing pressure, specifically an expanded or destroyed sella turcica. That's the bony depression at the base of the skull holding the pituitary gland. Hit all 3 of those, and you're officially looking at LOVA.
All right, section 3, clusters 1 and 2. Let's break these down.
Starting with cluster 1, which is known as incidental ventriculomegaly. These patients actually have normal intracranial pressure, or ICP. And because that pressure is normal, they really have the fewest symptoms. Honestly, most are totally asymptomatic, or maybe they just have a mild headache. We usually just stumble upon this by accident, like during a post-trauma workup. They're typically around 40 years old on average. Now, the mechanism here is wild. Some of these patients actually develop a spontaneous third ventriculostomy. Basically, the brain creates its own internal bypass for the fluid. It perfectly explains why they feel fine. Since they're stable, management is super conservative. We're talking annual surveillance, and if they do get headaches, standard analgesics or sometimes acetazolamide will do the trick.
But contrast that sharply with cluster 2, decompensated ventriculomegaly. Guys, this is the danger zone. Unlike cluster 1, these patients have high ICP and are incredibly symptomatic. They often show up acutely with gait issues, visual changes, severe headaches, and urinary incontinence. A full 25% of them already have cognitive deficits. In extreme cases, they can deteriorate really rapidly. These patients are typically middle-aged, and anatomically speaking, exactly 1/3 of them, 33%, have severe aqueductal stenosis driving this dangerous backup of fluid. To put a very specific number on that high pressure, cluster 2 patients present with an elevated mean ICP of exactly 14 millimeters of mercury. And trust me, that elevated pressure dictates an immediate shift in how we handle things. Because of that high pressure and the risk of rapid deterioration, watch and wait surveillance is completely off the table. For cluster 2, the recommendation is definitive CSF diversion. Usually that means a VP shunt or an endoscopic third ventriculostomy, an ETV. But here is a massive clinical pearl you have to remember. Even after successful treatment, the ventricles themselves tend to stay enlarged. You're treating the pressure, not necessarily the visual size of the ventricles on the scan. Don't let the post-op imaging fool you. Moving right along, Section 4, Clusters 3 and 4. Okay, Cluster 3, Early Presenting Ventriculomegaly. As the name hints, these folks are younger. Mean age is roughly 29 years old. Visually on imaging, they have the absolute largest ventricles across every single cluster we're talking about today. And symptomatically, they are miserable. Literally 100% of them complain of headaches, and 30% have nausea. Plus, if you dig into their history, 25% of these patients will have a documented history of prematurity, complicated by a germinal matrix hemorrhage. Now, the physiological paradox here is what's really fascinating. Just like Cluster 1, Cluster 3 patients actually have normal baseline ICP. So you're probably wondering, why on earth are they so symptomatic with such giant ventricles? Well, it all comes down to abnormal pulsatility. Even though the baseline pressure is fine, the peak to low peak amplitude of their CSF pressure wave is way off the charts, averaging 5.2 millimeters of mercury. It is that constant pounding wave action causing all the trouble. Because of this, the go-to management for the vast majority of these early presenting patients is a shunt, simply to dampen that aggressive pulsatility. Let's flip over to Cluster 4, Late Ventriculomegaly. The demographic here shifts dramatically. We're looking at a much older population, mean age of 59, and it's far more common in women. Their main complaint? Always headaches. Clinically, this cluster is notoriously tricky, mostly because it mimics normal pressure hydrocephalus, or NPH, almost perfectly. You'll see the cognitive deficits, the gait issues, the urinary incontinence. But here's your key differentiator. Cluster 4 patients do not display that classic magnetic gait you see in NPH. Another big difference? We usually don't even measure ICP in this group because of various contraindications. And this is exactly why getting your cluster classification right matters so much. For Cluster 4, CSF diversion usually works well, producing real improvement. But there is a huge catch. Overdrainage is incredibly common in this older demographic, and with overdrainage comes a high incidence of subdural hematomas, which is that dangerous pooling of blood just outside the brain. So the strict recommendation here is you absolutely should consider a programmable valve. It lets you carefully dial in that drainage and hopefully dodge those complications. Which brings us to our final group, Section 5, Cluster 5, Panventriculomegaly. Cluster 5 is panventriculomegaly. Now, the defining anatomical feature that sets this apart is the overt involvement of the fourth ventricle alongside all the others. The history profile is honestly pretty staggering. A full 50% of these patients have a history of some kind of prenatal injury. And their symptoms? It's a very severe neurological picture across the board. 50% suffer from gait disturbances, 50% have cognitive deficits, and a massive 88% suffer from epilepsy. Oh, and there's a highly specific symptom unique to this cluster's anatomy. Because that fourth ventricle is dilated, it can actually physically press right up against adjacent brainstem structures. This means these patients can easily develop dysphagia or difficulty swallowing. Despite how incredibly complex this presentation is, the definitive management recommendation remains surgical, putting in a ventricular shunt to relieve that global fluid burden. All right, we have systematically unpacked every single point of adult ventriculomegaly and the 5 diverse clusters of LOVA exactly as they're laid out in the source material. So I'm going to leave you with this one final thought. With such vastly different presentations across these clusters, from a totally asymptomatic 40-year-old incidental finding to a rapidly deteriorating patient to an older woman at high risk for a subdural hematoma, how is mastering this strict cluster classification going to change your approach the very next time you pull up a brain scan? Thanks so much for joining me on this explainer. Keep learning, keep questioning, and I will see you next time.